So hello all of you, a very good evening to all. So welcome to this session of FMG Accelerate Dermatology session by PW MedED. So I hope that whoever has attended yesterday's session, you found it useful. So today also we'll continue with another around 25 to 30 questions in dermatology. So I hope your preparations are going fine, and please confirm me once if my audio as well as the video is all fine. So if you can let me know in the chat box, that would be great. So as soon as you confirm it, I shall be continuing with the sessions. So what we will do is, yesterday we had discussed almost 23 to 25 questions. So we'll continue from wherever we had left yesterday. Fine. So just give me a minute. So we would be continuing from question number 25. We'll be continuing from question number 25. So audio and video are clear. Okay, thank you so much for your confirmation. So now let's begin with this first question of the day. So I hope all of you are ready. So the first question is, a truck driver with a non-pruritic lesion all over the body, including the palms, with oral ulcer, what is the most probable diagnosis? And there are two images that is given, and you can see that there is an image of the trunk where there is a coppery kind of a macular lesion, and there is also an image of the palms where there also you can find a copper colored macular lesions over the palms. Now, what does all these things indicate? A truck driver, every time you get a question about a truck driver, more or less it is going to hint you about probably some STI, and then it's a non-pruritic lesion. Non-pruritic means it is not an itchy lesion, isn't it? So Jayasurian is answering it as B, Khan is answering as B. So is it right? Is it secondary syphilis? Absolutely yes. Well done. So this is going to be secondary syphilis, isn't it? Why? Because what are these lesions that you see? All these are typical lesions that you can see in secondary syphilis. Now, do you remember what are the lesions that you see? When it comes to secondary syphilis, so how do you differentiate whether a patient is having a primary syphilis or a secondary syphilis? See, what happens is that when it comes to primary syphilis, what are the clinical features that you expect? You are expecting that a patient may be having a ulcer, isn't it? That is a genital ulcer. So a patient may have a hard chancre plus inguinal lymphadenopathy is expected, plus inguinal lymphadenopathy is expected when it comes to a primary syphilis. Now, what happens when the patient proceeds into secondary syphilis? The difference is that this inguinal lymphadenopathy is going to become a generalized lymphadenopathy. It is going to become a generalized lymphadenopathy. So along with this generalized lymphadenopathy, there are multiple other lesions that can be seen, and one of this lesion is this copper colored macules over the trunk, and also these kind of pigmented rashes that you can see over the palms and soles. So you can also see pigmented rashes over palms and soles. So all these can be seen. Now, did you see that in this MCQ they also mentioned you about a oral ulcer? So can anybody make a guess about what is the type of oral ulcer that you can see in secondary syphilis? Any guess in the chat box? So very good afternoon, MedPsycho. Nice to see you back. So can anybody answer me, like, what is the type of aphthous ulcer or the oral ulcer that you can see in secondary syphilis? So this is compared to a snail track ulcer. It is compared to a snail track ulcer. Fine. So along with the snail track ulcer, one of the other finding which you can see in secondary syphilis is called as a mucus patch. You can also see a mucus patch. So all these are various findings. Now I'll just add one more finding before we go to the next MCQ. What is the type of alopecia that you can see in secondary syphilis? It also has a very typical name. For this type of an alopecia, multiple patchy alopecia that you can see over the scalp of a syphilis patient. What is it called as? This is going to be compared to a moth-eaten alopecia. So moth-eaten alopecia. So these are the various findings that you can see in a patient of secondary syphilis. Fine. So very good, Rahil, MedPsycho, all of you, whoever is answering. So excellent. So I hope that this question is all clear. So here the right answer was secondary syphilis because of the typical lesions that has been mentioned in this question. So now let's move to the next one. So identify the condition that is shown in this image below. So excellent, Jayasurian, that you are also right about moth-eaten alopecia. Now let's see what is this. Identify the condition that is being shown. So what do you see in this image first? Don't look into the options, just see the image first. Now in this image you can see that there is a hypertrophy, isn't it? Especially of the nasal area over the nose. So there is a change in consistency of the skin as well. Now what is this? Is it rhinophyma? Is it rhinoscleroma? Is it SLE or acne vulgaris? So all of you are answering it as A, rhinophyma. Excellent. So what is rhinophyma? What is a common name of rhinophyma? It is also called as potato nose. It is also called as a potato nose. Now what is happening in this rhinophyma? What is the gland that goes into a hypertrophy here? Is it a sweat gland? Is it a sebaceous gland? Or is it something else? So what is happening here? Yes, MedPsycho, it is potato nose. So there is a hypertrophy of the sebaceous glands. So there is a hypertrophy of sebaceous glands when it comes to rhinophyma. Fine. Now what is that type of a disease in dermatology where you can find a potato nose? Because otherwise rhinophyma you can count it under ENT, right? Now what is that thing which makes the skin red over this part of the face? Now what makes the skin red? What is the name of the disease? So this is, yes, Rahil, MedPsycho, all of you are answering. Swaminathan, Satyajit, all of you are answering. Excellent. Now this is going to be associated with a disease called as a rosacea. So this is associated with a disease called rosacea, where the patient can sometimes present to you with the complaints of a hypertrophy of the sebaceous gland. Now, in such cases, does any medication help to treat rhinophyma, or should we go for a surgical correction? So what is the treatment here? The treatment here is going to be either go for a surgical correction. So Jayasurian is saying SLE and rosacea. Excellent. Those are very good two differential diagnoses for this kind of an image. But in this case, since it is more likely to be rosacea. Very good thinking, Jayasurian. And then what is a laser that can be used for the management of rhinophyma? Can you give it a try? So what is a laser? The laser which can be used for the management of rhinophyma is CO2 laser can also be used. So CO2 laser can also be used for the management of rhinophyma. So very good, all of you. Jayasurian, Swaminathan, all of you are answering. Now, since we are already discussing about this topic called rosacea, can we quickly do a short revision about rosacea? Now in rosacea, what is the most common type of rosacea? Most common type of rosacea is called as, excellent Khan, so you are answering it as CO2 laser. Very good. So Rahil is also answering it as CO2 laser excision. Excellent. Now who can tell me what is the most common type of rosacea? Yes, the most common type of rosacea is going to be erythematotactic type. Okay, where there is an erythema of the face along with some dilated blood vessels can also be seen. That is called as erythematotactic type, which is going to be the most common type of rosacea. Now, one more question. In case you do a KOH test over the face of a patient with rosacea, there is a likely chance that you may find some tiny mites over the skin. Tiny mites are seen under the KOH, under the microscope. Now, what are these tiny mites you see in the skin called as? So these are tiny mites in the skin of rosacea patient, what is it called as? So this is called as Demodex mites. These are called as Demodex mites. Okay. So Demodex folliculorum or Demodex mites, this is the name of the very peculiar type of mites that you can see in the case of a rosacea. Fine. So very good. Whoever is trying, keep trying. Okay. Keep going. So with your permission, I'll proceed further. So I'm going to the next question now. Identify the condition that is shown in this image below. So in this image, you can see that there is a nail finding that is shown. So what exactly is the finding that you can see? You can see that there is a thickening beneath the nails. Okay, or there is a thickening just below the nails, isn't it? Now, what do you call for this kind of a thickening? Is it onychomycosis? Is it nail fold keratitis, subungual hyperkeratosis, or yellow nail syndrome? What is it? So who can give it a try? In the chat box, please. So this is going to be, is it A, B, C, or D? Yes. So since there is a increased thickening beneath the nails, this is called as subungual beneath the nails, है ना? Or hyperkeratosis. There is a thickening. So this is called as subungual hyperkeratosis. So yes, Khan, MedPsycho, all of you are answering. So this is called as subungual hyperkeratosis. Now, in which disease can you see the subungual hyperkeratosis? So can you name the disease? So this can be seen in a disease called psoriasis. So this is a finding in a disease called psoriasis, but please try to remember that since they have asked you already about subungual hyperkeratosis, they can give you any other image that you can see in psoriasis, correct? Now let us try to remember what are the nail findings in psoriasis. You can remember it with the mnemonic poison. Okay, you can remember it with the mnemonic poison. Now what is P? P stands for pitting of the nails. Pitting of the nails. Now this pitting of the nails is going to be the most common nail finding in psoriasis. So please make a note that this is the most common finding. Whereas OI can be called as oil drop sign. Oil drop sign. And this oil drop sign is going to be the most characteristic nail finding in psoriasis. This is the most characteristic. It is the most characteristic finding. So S stands for the same thing which we have seen just now in this MCQ, that is subungual hyperkeratosis. Hyperkeratosis. Okay, very good. MedPsycho, Jazeer, and all of you are guessing it right. And then O. So what is O? O can be onycholysis. So onycholysis means the nail is getting detached from the nail bed, especially over the extremities. So this is called as onycholysis. And finally N. N stands for nail plate dystrophy. So the entire morphology of the nails may be lost, and this is called as nail plate dystrophy. So these are the various findings which you can see when it comes to psoriasis nail findings. So remember it as poison. Okay, poison, out of which the most common is going to be the pitting of the nails, and the most characteristic is going to be the oil drop sign. Fine. So now let's move to the next one. A patient with a non-case of TB has been taking multiple medications, and now he has presented with the given image. What is the most appropriate diagnosis for this patient? So now in the question they have mentioned that is a non-case of tuberculosis. So the patient has been taking multiple medications. Okay, the patient is on anti-tubercular drugs probably, and now the patient has presented something like this. Now let us zoom this image. Let us see what how the patient has presented. Can you see that there are very large areas of erosion over the trunk of the patient? So this is how the patient has presented to you. So what is the answer? So many of you, Khan, Jayasuriyan, Rahil Sheikh, all of you are answering it as B. Excellent. The answer is B here. Now can you tell me why do you say that this is toxic epidermal necrolysis and why it is not Stevens-Johnson syndrome? So why it is TEN and not Stevens-Johnson syndrome? What is your answer for that? Yes, I agree that all of you are answering it as TEN. And what is the reason? So, remember that in this MCQ, the patient has been taking on multiple medication. After taking the medication, there is a massive peeling of the skin. How does the patient usually present to you with a Steven-Johnson syndrome or toxic epidermal necrolysis? Yes, very good. Satyajit is answering because the body surface area is more than 10%. Excellent. That is the right answer. See, how do you divide this thing? Like in Steven-Johnson syndrome, the total body surface area that is involved is usually going to be less than 10% body surface area. Whereas when it comes to toxic epidermal necrolysis, the body surface area that is involved is usually going to be more than 30% of body surface area. Now, in case you get a patient in between 10 to 30, that is in between 10 to 30 percentage, this is going to be Steven-Johnson syndrome, toxic epidermal necrolysis overlap. So this is going to be overlap. So Jaisurian, Satyajit, all of you are answering it right. So that is the right answer. So since we have a more of a body surface area that is involved, so this can be a case of toxic epidermal necrolysis. Now tell me, in toxic epidermal necrolysis and Steven-Johnson syndrome, are you expecting any involvement of the mucosa? Let us say the oral mucosa or the mucosa of the eyes, are those involved as well? So please remember that when it comes to Steven-Johnson syndrome or toxic epidermal necrolysis, there is massive erosions plus there is an involvement of at least two mucosa. There is an involvement of at least two mucosa. That is how the patients may usually present to you. Now, so just to understand what is the prognosis of the patient, do we follow any kind of a scoring for the patients of Steven-Johnson syndrome or toxic epidermal necrolysis? What is the right answer? What is the scoring system for prognosis? Scoring system for prognosis. It comes with a very specific name. What is it? Scoring for 10 means score 10 scoring. So this is score 10 scoring. So score 10 scoring is done to assess the prognosis of a patient with toxic epidermal necrolysis. Fine. So that is all about TEN and SJS. So now let's move to the next question. Now moving to the next one, what do we find here is that a patient comes to the OPD with the lesions as shown in the image along with few satellite lesions. Identify the condition. So what you see in this patient? Patient is having a hypopigmented patch. And the question says that the patient is also having some satellite lesions. Fine. So in this satellite lesions, now whenever you see this thing about satellite lesions, what comes to your mind? So MedPsycho is answering it as B. Does all of you agree that this is a BT type of leprosy? So now let us quickly see what are the typical features. Now listen to this carefully. Whenever you get a question on leprosy, it is most likely that the examiner may give you some clue about what is the kind of lesion that is being seen. Okay, for example, in this question we got a clue that there is a satellite lesion. Now, what are the different types in the TT type of leprosy? What is the kind of lesions that we see or how the lesions can be compared? The TT type of leprosy can be compared to a saucer right way up appearance. So there is a cup and saucer, right? So this is a saucer right way up appearance. If it is mentioned in the MCQ, it is going to be a TT type of leprosy. Now what will happen if it is BT type? So BT is what you are telling right now, that you can see satellite lesions, which you have rightly answered. And sometimes we can also see some finger-like projections. These are also called as pseudopodia. Pseudopodia can also be seen. Fine. Now moving to the next one, that is BB type of leprosy, borderline type of leprosy. So earlier it was saucer right way up, right? Now we are going to invert the saucer. So this is going to be a inverted saucer appearance. So this is going to be a inverted saucer appearance. Some textbooks also mention this as a Swiss cheese appearance. Okay, Swiss cheese appearance. Some textbooks also mentioned as a geographical map appearance. So all these can be seen in the case of a BB type of leprosy. And remember, once a patient progresses into BL type of leprosy, the patient will start getting almost symmetrical type of lesions. So this is going to be almost symmetrical lesions, almost symmetrical lesions. And finally, when you come to the lepromatous type of leprosy, what are the type of lesions that you expect in this patient? So in lepromatous type of leprosy, you can see a typical kind of a face which is compared to leonine facies. That is a lion-like face, that is leonine facies can be seen. Along with that, you can see a saddle nose deformity, multiple nodules over the face, etc. So all these things can be seen when it comes to a lepromatous type of a leprosy. So remember that this slide is very important because every time they may ask you these questions about leprosy, and please make sure that these are the hints that will guide you to the right answer. Fine. So TT, BT, BB, BL, LL. So make sure that you know all these 5 types of presentation when it comes to leprosy. So in this question, the answer was BT type of leprosy. So let me continue further. Identify the psoriatic nail change. I think it is the same thing, right, which we have discussed just now. So this is going to be the same thing. Yes, Satyajit, you're answering everything right. Lion-like face and depressed nasal bridge, all correct. Very good. Now this is again the same thing, subungual hyperkeratosis. Now in this oil drop sign we have already discussed, correct? So oil drop sign is also a nail finding in psoriasis. Whereas what is Auspitz sign? Do you remember? Like I think yesterday we mentioned about Auspitz sign. So in case you scrape over the lesions of a patient of psoriasis, psoriatic plaque, what happens? Pinpointed bleeding spots can be seen. That is called as a Auspitz sign. That is called as a Auspitz sign. Now what is the fourth option? Cobner's phenomenon. Now what is Cobner's phenomenon? Who can answer? So Cobner phenomenon, yes. So explain again, which one do you need to be explained? Yeah. So regarding Auspitz sign, if you want me to explain, what happens in an Auspitz sign is, just imagine that you have a patient of a psoriatic plaque. So there is a plaque lesion here. So if you take a glass slide and you start scraping over these lesions, what will happen? Once you continue scraping, finally you can find some pinpointed bleeding spots, okay, over this plaque, and this is called as Auspitz sign, which can be typically seen in a psoriatic patient. Now coming to Cobner's phenomenon, what is Cobner's phenomenon? Whenever you find new skin lesions appearing at this site of trauma. So when new skin lesions start appearing at the site of trauma, it's called as a Cobner's phenomenon. For example, you have done a small skin biopsy. So at the site of skin biopsy, a patient develops a psoriatic plaque or a vitiligo patch. This is called as a Cobner's phenomenon. So please try to remember, there are 3 diseases where you can find this Cobner's phenomenon. You can remember it as LVP. Now what is L? So L stands for lichen planus. V stands for vitiligo, and P stands for psoriasis. Fine. So LVP, that is lichen planus, vitiligo and psoriasis. So these are the 3 findings that 3 diseases where you can find a Cobner's phenomenon. So SAT short videos was asking about option A. See, option A, that is oil drop sign. This is one of the findings that you see in a psoriatic patient over the nails. So I don't have the image as of now, but these images are given in our app. So next time I'll be able to show you. So whenever you find this oil drop sign as a change over the nails, this is seen in a psoriasis patient. Fine. So this is about Cobner's phenomenon. So now let's move to the next question, like identify the type of lepra reaction shown in this image. So the question itself says that it is a lepra reaction. So how many types of lepra reaction is there? So there are going to be two types of lepra reactions basically, isn't it? Type 1 lepra reaction and type 2 lepra reaction. Now options it is given type 3, type 4. Let us roll out type 3 and type 4 first. Fine. So now what is given in this image? Can you make a guess like what is the type of leprosy in this patient, so that this will be easy for us to reach the answer here. First look at the image and make a guess what is the type of leprosy. Options are TT, BT, BB, BL, LL. So what is the type of leprosy in this patient? You can see that the patient is going to have multiple nodular lesions over the face. There is a saddle nose deformity of the nose, isn't it? So putting all these things together, it is highly likely that the patient is having a LL type of leprosy. So in lepromatous type of leprosy, what is the kind of lepra reaction that is expected? The answer is yes. The correct answer is going to be type 2. So Jayasurian, Khan, Satyajit, all of you are answering it as right. So this is going to be type 2 lepra reaction. Fine, this is going to be type 2 lepra reaction. So let us do a quick revision of what are these types of lepra reaction. Very quick revision. Fine. So in this type 1 lepra reaction, this is also called as a reversal reaction, whereas type 2 lepra reaction is called as erythema nodosum leprosum. Erythema nodosum leprosum. Now the very important thing that you will remember is which are the clinical types in which you can see this type 1 lepra reaction. Remember that type 1 lepra reaction is seen in all the borderline types. So how many borderline types of leprosy do you remember? So the first type of borderline leprosy is going to be BT, then comes BB, and then finally comes BL. So all the borderline types of leprosy is going to show type 1 lepra reaction. Whereas which are the types of lepromatous leprosy? So that all the types of lepromatous leprosy is going to show a type 2 reaction. Now what is it going to be? This is going to be BL and LL. Fine. Remember all lepromatous type 2, whereas all borderline type 1. Now in all these cases, it was once tested like what should be the ideal management. So what is the ideal management in both type 1 and type 2 lepra reaction? The ideal management is going to be continue multi-drug therapy for leprosy. So you should not stop anti-leprosy treatment. So you have to continue on multi-drug therapy for leprosy, and then you have to start on steroids. So that is going to be the management in lepra reaction. So please make sure that this lepra reaction is not a drug reaction. Fine, it is not a drug reaction. So we are not going to stop the drugs. Like what are the drugs that we use to manage leprosy? Like rifampicin, clofazimine, dapsone. We will not stop it. We'll continue, but we will start on steroids like prednisolone. So that is all about. Yes, we can also use NSAIDs when it comes to this lepra type 2 reaction, because this erythema nodosum leprosum can be painful subcutaneous nodules. Fine, and the patient may have some systemic symptoms as well. So you are all correct. Satyajit is adding one more point, thalidomide. Very good. So in which type do we use thalidomide? Thalidomide can be used for type 2 lepra reaction, but it is less preferred because of the teratogenicity. Okay, thalidomide can be used in type 2. Okay, in type 2 lepra reaction. But steroids is going to be the drug of choice. Remember that prednisolone or systemic steroids is going to be the drug of choice. So very good. So all of you seems to have done a very good revision. So now let's move to the next one. So I hope it is clear. So now let's continue to the next question. Identify the condition that is shown. So it is multiple signs of phenomenon that is being tested here. First one is Darier's sign. Option B is Auspitz sign. Third one is dermographism. And the fourth one is Koebner's phenomenon. So what is the right answer here? So you can see that earlier, do you remember that in few MCQs back, we have discussed about Koebner's phenomenon. So yeah, Metsyko is answering, S is answering, Khan is answering. So all of you know that this is going to be a Koebner's phenomenon, correct? So what is happening here is that the patient is going to have any of these diseases like psoriasis, lichen planus, or vitiligo. So when the patient has scratched his own skin, so this is considered to be a trauma, correct? So after scratching, the patient has developed these lesions on the area of wherever he has scratched over the skin. So this kind of a phenomenon where you find new skin lesions at the site of trauma is called as a Koebner's phenomenon. So this is going to be Koebner's phenomenon. How about the other options that you see in this MCQ? Like, where do you find Darier's sign? Can you answer? Where do you find Darier's sign? So yes, Darier's sign is not seen in Darier's disease, but instead this is seen in a disease condition called urticaria pigmentosa. So Darier's sign can be seen in a disease called urticaria pigmentosa. Like if you stroke over the skin of this patient, the patient may develop some urticarial wheals. Remember? So Darier's sign is seen in urticaria pigmentosa. Auspitz sign, though we have already discussed, that is seen in psoriasis. And where do you find dermographism? So dermographism can be seen in chronic urticaria, isn't it? So especially red dermographism can be seen in chronic urticaria. Very good. Satyajit is answering it as the urticaria. Very good. Now, can I ask you one more question? Like, where do you find this white dermographism? So where do you find white dermographism? Any guess? Like Satyajit just now answered that it can be seen in urticaria. How about white dermographism? Very good. S is answering it as atopy. Yes, this is seen in atopic dermatitis. Atopic dermatitis. Excellent. Very good. Very good. So these are the various findings that you see in all these diseases. So now let's move to the next question. Now, patient having no history of fever in the past developed nodular lesions over the face. Identify the condition given in this image. Yeah, Raj Rana, S, all of you are answering it as atopic dermatitis. Very good. There's a short delay in getting these messages. So good. So now let's move to the next question. So what is this next question? This is a patient with having no history of fever in the past and has developed multiple nodules over the face. Again, this is one of the image of which type of leprosy? Yes, Rajrana. So this is going to be lepromatous type of leprosy, like a leonine face is, right? So here the answer is going to be leprosy. Okay. Now, why has the examiner tried to give you this clue that there is no history of fever? So in case the question would have been a patient with a long-standing history of fever in the past develops multiple nodular lesions over the face, then the answer would have been changed. Then the answer would have been this one called post-Kala-Azar dermal leishmaniasis. Fine, post-Kala-Azar dermal leishmaniasis. So please make a note of it that when it comes to PKDL, that is post-Kala-Azar dermal leishmaniasis, it will be a patient with history of long-standing fever in the past. Fever in the past. But the clinical symptoms is going to be very similar to lepromatous leprosy. Now, what is the clinical symptoms in lepromatous leprosy? The patient may have numerous hypopigmented patches over the trunk along with nodular lesions over the face, isn't it? So that is how it is going to be represent. It is going to be the same. The difference you have to make sure based on the history of fever. Fine. So Jayasurya, Satyajit, all of you are answering. Excellent. Now let's move to the next one. Now, the shown lesions are, it's a spot diagnosis. So you can see multiple papular lesions are given. Now, what is the diagnosis? So if you start observing these lesions very carefully, it is very easy to understand the diagnosis. It's a spot diagnosis. What is the peculiarity of these papules? There are multiple papules can be seen, and you can see that there is a dip in the center. So this is called as a central umbilication. This is called as central umbilication. Yes, S is saying should be Bihari. Yeah, Rajrana is answering. It is called as molluscum contagiosum. Molluscum contagiosum. Excellent. So Rajrana, Jayasurian, all of you are answering it right. So here, how does a patient usually present with molluscum contagiosum lesions? They present with dome-shaped, umbilicated papules. They present with a dome-shaped umbilicated papules. Now what happens in this case of a molluscum contagiosum is that the patient, usually it is seen in children, so this child may have developed this one lesion first. So what happens whenever you find any kind of a papular lesion over our skin, we have this tendency to repeatedly touch over these lesions, correct? So when we repeatedly touch over this lesion and then touch the adjacent skin, what is happening? There is a auto inoculation of the virus that happens to the adjacent skin. So because of auto inoculation, the patient develops the second lesion, then develops a third lesion, then develops a fourth lesion. Now what is this phenomenon that is being seen in this image? Can you answer what is the name of these lesions that you can see? So S is saying umbilicated lesions are, yeah, it can also be seen in histoplasmosis. Sometimes you can also see these kind of lesions in sweet syndromes as well. Fine. Now, what about this one? One lesion followed by the other, followed by the other, because of auto inoculation of the virus. This is called as pseudo-Koebner's phenomenon. So S is answering it right. So pseudo-Koebner phenomenon. This is due to auto inoculation of the virus. So this is due to the auto inoculation of the virus. So this is usually seen in viral diseases, isn't it? So one is molluscum contagiosum virus. This can also be seen in viral warts caused by human papilloma virus. So Raj Rana is adding one more additional point, like what happens in the histopathology. Excellent. So what is the histopathology finding in molluscum contagiosum? It is a peculiar bodies called as HP bodies. What are HP bodies? Henderson-Peterson bodies. Henderson-Peterson bodies can be seen on histopathology of molluscum contagiosum. Okay, so that is going to be the difference. See, histoplasmosis is not going to be a very common infection, whereas this molluscum contagiosum is a very common thing that you can see in the OPD, usually seen in children. The only thing that you have to pay attention is that, see, histoplasmosis and all, you will have to check regarding the immune status of the patients, right? Because all these kinds of diseases can be seen mostly in the immunocompromised patients as well. Okay, so especially when it is going to be disseminated. Whereas when it comes to molluscum contagiosum, just pay attention to one thing that usually seen in children, whereas when it comes to adults, especially if molluscum is seen over the genital area, then this may be transmitted as a sexually transmitted infection. Fine. So it can be a STI provided that you find these kind of dome-shaped umbilicated papules over the genitals or the groin area in adults. Fine. So that is it. Usually treatment is not necessary. It is self-limiting in an almost 6 to 12 months time. But cryotherapy, electrocautery, all these things can also be tried. Fine. Yes, Satyajit, like in disseminated histoplasmosis, there can be a manifestations of lungs as well. Excellent. So that is how it can be treated. Fine. Very good. Now let's move to the next one. So a 25-year-old female presents with a history of fever and oral ulcers and has developed erythematous lesions over the face. Comment on the diagnosis. So there is a fever, there is oral ulcers, and there is some erythematous lesions over the face. Now it's pretty direct question, and you can see that in this image that there is a sparing of the nasolabial folds as well. So somebody who is having some systemic symptoms like fever, there may be some aphthous ulcer, and there is a rash over the face which may look like a butterfly. What is it? So this is more likely to be a systemic lupus erythematosus. What is the name of this rash that you see over the face in SLE? So this is called as malar rash. So this can be called as a malar rash. Now can you tell me that these aphthous ulcers that you see in SLE, is it going to be a painful ulcer or a painless ulcer? What do you think? The ulcers, the aphthous ulcers in the mouth that you see in SLE, is it going to be painful or painless? So this is going to be painless aphthous ulcers can be seen, and obviously the patient is going to have a photosensitive rash, isn't it? Photosensitive rash. Can anybody tell me what is the color of the lesions when it comes to dermatomyositis? What is the color of the lesions in dermatomyositis? So let us write down some of the salient features. So Jayasurian, Raj Rana, all of you are answering it correct, whatever I've asked you. Now I'm going to ask you about dermatomyositis. Now what are the features that you remember? Is it a red color rash or is it a violaceous colored rash, purple colored rash? So this is going to be a violaceous rash, isn't it? It can be compared to a heliotrope flower. Heliotrope flower. Okay, very good. And then what happens is that, is there any findings over the hands of the patient of a dermatomyositis, like over all these joints? Does the patient get some kind of a papillary lesion? Yes. So what are those called as? These are called as Gottron's papules. These are called as Gottron's papules, because these were also some of the questions that were asked. So let us try to discuss these also. So a patient may have a violaceous rash. It can be compared to a heliotrope flower, and then the patient may be having some Gottron's papules, especially over the knuckles or the interphalangeal joints. Okay, that happens in dermatomyositis. Now, how about this case called melasma? How does a patient usually present with melasma? What is the color of the rash in melasma? So very good. Vamik, Medpsycho, Khan. Yeah, S is also saying that there may be periungual telangiectasia. Excellent. That is also one of the finding. Periungual telangiectasia can be seen. Excellent. You can also see shawl sign. There may be a V-shaped erythema. So all these can be seen. Holster sign can be seen. So there are multiple findings that you can see in dermatomyositis. Excellent. So happy to get these answers in the chat box. Now I'm coming back to this next option called as melasma. Now what is melasma? What is the color of the rash? The patient may develop a brownish hyperpigmented patch lesion, isn't it? So you can find a brownish patches over the sun exposed areas or face. Okay, let us say that there is brownish hyperpigmented patches over the face, brownish colored patch. So what else? Medpsycho is saying it is mostly seen in pregnant women. So yes, since you have told that melasma can be seen in pregnant women, now tell me, what do you call for melasma when it happens in pregnancy? So melasma in pregnancy, it is called by another name. So what is the name of melasma that you see in pregnancy? It is called as cloasma, or the mask of pregnancy. So cloasma or mask of pregnancy, usually yes, it happens because of this hormonal differences. Some patients who may be taking oral contraceptive pills, and of course it can also happen because of sun damage when somebody is not using sunscreens and all. Now what is the drug of choice when it comes to melasma? What is the drug of choice? The drug of choice when it comes to melasma is going to be obviously a skin lightening agent. So what is the name of the skin lightening agent? This skin lightening agent is called as hydroquinone. It's called as hydroquinone. So very good. Mask of pregnancy says Khan. Hormonal. Yeah, fine. All of you, whoever has messaged in the chat box, all of you are right. Excellent. So please remember, hydroquinone is going to be the drug of choice in melasma. So now let's move to the next question. The following lesion was noticed in a patient with obesity. What is the diagnosis? So the following lesion was seen. So what can you see? It is probably seen over the neck area, or sometimes it can be seen over the axilla, isn't it? Over the body folds also. So what is this? This is called as acanthosis nigricans. Now what is acanthosis nigricans? How can we explain about this lesion? Yes, Metpsycho, Satyajit, all of you are answering it right. So please remember, it is not actinic keratosis. It is going to be acanthosis nigricans. Khan, Rajrana, all of you are right. See, what is the type of lesion that you see in acanthosis nigricans? You can see a hyperpigmented velvety lesion. And one of the most common sites where you can see acanthosis nigricans can be over the neck or behind the neck. So sites can be behind the neck, over the axilla, etc. Now, in which is the type of those patients in whom we can see these kind of acanthosis nigricans, or what is the most common association? So this is most commonly associated with, is it diabetes, is it obesity, or is it something else? Yes. So found in metabolic syndrome, velvety skin. Yes, correct. But what is the most common association? Most common association is what is being mentioned in this MCQ, that is obesity. It is most commonly associated with obesity. It can also be associated with some diseases like diabetes. It can be associated with PCOD or PCOS, polycystic ovarian disease, isn't it? So any hormonal imbalance or metabolic syndromes. So all these are the commonest associations. But please remember that in one of the NEET PG exams they asked like whether acanthosis nigricans can be associated with malignancies also. So what is the right answer? Yes, rarely associated. So this can be rarely associated with malignancies as well. So it can be rarely associated with malignancies as well. So yes, very good. S is also messaging it can be associated with malignancy after 55 years. Excellent. So all these can be seen when it comes to acanthosis nigricans. Now who remembers what is the second option, that is lesser Trillat sign? So do you remember what is lesser Trillat sign? So this you must have also learned in surgery, that is lesser Trillat sign. So what is lesser Trillat sign? Stomach and liver cancer, says Jayasurian. Satyajit says GI malignancy. Excellent. So this is a marker of malignancy, isn't it? And what malignancy? Usually it is going to be GI adenocarcinoma. So this is going to be a marker of malignancy usually associated with GI adenocarcinoma. And what is lesser Trillat sign? When there is a sudden eruption of multiple seborrheic keratosis over the trunk. So when a patient develops multiple seborrheic keratosis over the face or the trunk of the patient, then we have to suspect that the patient may be having a GI adenocarcinoma. So we'll have to investigate the patient. So this is called as lesser Trillat sign. Fine, very good. So now let's move to the next question, that which is not correct about the lesion that is shown in this image below. What is the right answer here? What is shown? That there is a patient who is having an erythematous background, and over this background of erythema you can see that there are multiple grouped vesicles. So grouped vesicles on an erythematous background without crossing the midline. What is the diagnosis now? So here the diagnosis becomes herpes zoster, correct? Now what is herpes zoster? Herpes zoster is going to be the reactivation of varicella virus, or the first infection is going to be chickenpox. When there is this reactivation of the same virus, what happens? This is going to be herpes zoster. Now let us see all these options. So S, Jayasurya, Rajrana, all of you are saying C. So let's see the options. The lesions are infectious. Obviously yes. It can be associated with meningoencephalitis. In severe cases, yes. Bilaterally symmetrical dermatomal vesicular eruption. It is actually dermatomal vesicular eruption, but is it bilaterally symmetrical? No, it is going to be unilateral. It does not cross the midline, correct? So this is going to be the wrong answer. And geniculate ganglion is involved in Ramsay-Hunt syndrome. Yes. So all these are right. So this is always going to be asymmetrical. Excellent. So this is going to be asymmetrical. These lesions do not cross midline. The lesions do not cross midline. Fine. So in herpes zoster, let us quickly revise some of the important points in herpes zoster. So in herpes zoster, what is the most common complication? So what is the most common complication that is associated with herpes zoster? Can you answer? So the most common complication is going to be post-herpetic neuralgia. The most common complication is going to be post-herpetic neuralgia. And how do we take care of this post-herpetic neuralgia? So what is the drug of choice in this case? So this post-herpetic neuralgia can be taken care by gabapentin. Isn't it? Gabapentin. Fine. So when it comes to this herpes zoster, always remember they can give you an image where there is a unilateral involvement, okay, without a bilateral involvement. And what else? Regarding Ramsay-Hunt syndrome. Ramsay-Hunt syndrome. So when does the patient is going to have this Ramsay-Hunt syndrome? When the sensory fibers of facial nerve is involved. When this sensory fibers of the facial nerve is going to be involved. So does anybody remember what are the triad or what are the three findings in Ramsay-Hunt syndrome? The findings in Ramsay-Hunt syndrome is going to be the patient is going to have a severe ear ache. So the patient is going to have a ear ache. And the second one, the patient may complain of tinnitus, isn't it? And once you examine the ear canal, what can you see? You can see vesicles over the ear canal, and then there may be a ipsilateral facial paralysis. There may be a ipsilateral facial paralysis. So all this can be seen when it comes to Ramsay-Hunt syndrome. Patient with severe earache, there is a ipsilateral facial paralysis, and there will be multiple vesicles within the ear canal. So this is called as Ramsay-Hunt syndrome. So very good, Satyajit, Jayasurian, all of you are answering. Now let's move to the next question. Infant presents with condition as shown below after a conjunctival infection. The shown condition is, what is it? Is it staphylococcal scalded skin syndrome? Is it epidermolysis bullosa simplex? Is it impetigo contagiosum or pemphigus foliaceus? Yes. So what is it? Yeah. So here this is more likely to be staphylococcal scalded skin syndrome. See what has happened in this baby? So you can see that in this baby there is some erosions over the entire body, isn't it? So there is an erosion over the trunk, over the face, etc. But what happens in staphylococcal scalded skin syndrome is that you can remember that there is no involvement of mucosa or oral mucosa. Because earlier when we talked about this multiple massive erosions like that you can see in the Stevens-Johnson syndrome or toxic epidermal necrolysis, in that case there was an involvement of at least two mucosa. You remember? So but in this case when it comes to staphylococcal scalded skin syndrome, there is no involvement of mucosa. There is only massive erosions. And why does the patient get these kind of a massive erosions? These erosions is due to the toxins that is released by Staph aureus in blood. This is due to the toxins that is released by Staph aureus in the blood. Fine. And then how does the patient present to you? Massive erosions plus fever. So since it is going to be due to staph toxins, what is the treatment? You'll have to treat the patient with The treatment is here going to be antibiotics plus fluids, because from this image itself you the baby looks like a burns patient, right? So there may be some dehydration, so you have to treat it with fluids along with antibiotics. That is a management of staphylococcal scalded skin syndrome. When it comes to 4S, please remember that this 4S is also called as Ritter's disease, or it is also called as pemphigus neonatorum. So on the day of exam, if they don't give you this option as 4S, instead they mention on the day of exam in the options as pemphigus neonatorum. So this is a synonym for the same disease called 4S. So please remember that as well. Okay, and S is mentioning in the chat box that there is a defect of desmoglein 1. Excellent. So there is a defect of desmoglein 1, just like the defect that you can see in pemphigus foliaceus when it comes to staphylococcal scalded skin syndrome. So Satyajit is asking what is the relation with conjunctivitis. See Satyajit, every time when it comes to staphylococcal scalded skin syndrome, the mother is going to give you a history that this infant or child had a history of a staph infection like staphylococcal conjunctivitis or a staphylococcal boil or a furuncle. So all these can be the preceding infection, after which the patient was not treated properly. So without taking a proper treatment or after taking a partial treatment, what will happen? The staph aureus will start entering the bloodstream. It will start releasing toxins in the blood. So that is what happens on the etiology of staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome and impetigo same hai. No. Yep. See, both like in impetigo, what happens? It can be either caused by a streptococcus or a staphylococcus. So whenever in an impetigo, somebody had a impetigo, if it was not treated, whenever any staphylococcal skin infection is not treated, it goes into a complication. And this complication is called staphylococcal scalded skin syndrome. Fine. Thank you so much. So now let's move to the next one. I think it is a repeat question once again. What is it? What is the spot diagnosis based on the clinical image? So what is the spot diagnosis? Based on the clinical image? Yes. Again, you can see a hyperpigmented velvety rash. So this is going to be acanthosis nigricans. Correct? So this is a repeat question once again. So let me just move to the next one. So what is the drug of choice for syphilis? A pretty direct question once again. So what is the drug of choice in syphilis? Is it ceftriaxone, erythromycin, tetracycline or benzathine penicillin? Why many of you are answering C? Okay, C was for the previous question, 42. Now what about this one? Yes. So when it comes to syphilis, remember that IM, that is intramuscular injections of benzathine penicillin has to be given. So benzathine penicillin is going to be the drug of choice when it comes to syphilis. So very good. So Vikas, Rajrana, MedPsycho, S, all of you are answering it right. Now let's see the next question. Now identify the condition shown below. Once again, it's a spot diagnosis. Now is it measles? Is it chicken pox? Is it herpes simplex or molluscum contagiosum? Molluscum contagiosum, we have seen it in a few slides ago. Now, how about the other three? Chicken pox also, I think we have discussed it yesterday. Now, it is between measles and herpes simplex. What is the answer? So this is going to be herpes simplex is more likely. See, always remember that on the day of exam, in case you find these kind of images, especially over the face, when there is some crusting that is seen, it can be either impetigo, okay, impetigo contagiosum, or it can be herpes simplex. Now still, how can you differentiate? Because in herpes simplex, just try to remember what is the commonest presentation. In herpes simplex, the commonest presentation is going to be a grouped vesicles on erythematous base. So when you get a group of vesicular lesion, that is fluid filled lesions on a erythematous base, it's called as herpes simplex. And when according to the site of these lesions, you can name it differently as well. So when it is going to affect around the lips, you call it as herpes labialis. Herpes labialis. So this lower lip and the lateral part of this lip, so this area is one of the most common sites of herpes labialis. So this is one of the most common sites of herpes labialis. So if it is a herpes infection, if they ask you what is the drug of choice, what is the correct answer? So what is the drug of choice when it comes to herpes simplex infections? So what is a drug that you would like to prescribe here? Yes, this is caused by HSV1. I agree, in 90% of the cases it can be caused by HSV1. So what is the drug of choice? The drug of choice can be an antiviral drug called acyclovir. So the drug of choice can be acyclovir. Is it clear? So very good. Satyajit is also answering. Excellent. So now let's move to the next one. What are these lines called as? So Jazeerian, MedPsycho, all of you had answered the previous one. Excellent. So now let's see this question of what are these lines. So these are some lines that you see over the skin. Now from this, is it some lymphatic development lines? Is it dermatomes? Is it Blaschko lines, or is it representing some vascular development? Yes. So Raj is answering it as C. Khan is answering C. S is answering C. Excellent. So these are Blaschko's lines. See these Blaschko's lines from these images. Yes, we can see these kind of lines. But is Blaschko's lines visible to our naked eyes? The answer is no, isn't it? So Blaschko's lines, always remember, these are invisible cell development lines. So these are invisible cell development lines. So in one of the MCQs they had asked, like, what are these lines actually corresponding to? Corresponding to the development of what cells? Is it some artery? Is it some vein? Is it some cells? Like, what is a cell called as? So this is usually corresponding to the keratinocytes. So these are actually corresponding to the development of keratinocytes, the most abundant cells in the epidermis. Fine. Now what happens, what is the significance of these Blaschko's lines for us is that when it comes to diseases, there are some diseases which follow Blaschko's lines. Fine. We can see some diseases that may be seen over the Blaschko's line in a peculiar pattern. Now you can remember these diseases as another mnemonic, that is HIE. Now what is HIE? So H is for hypomelanosis of Ito. Okay, hypomelanosis of Ito. I is for incontinentia pigmenti, and E is for epidermal nevus. So in all these things like epidermal nevus, incontinentia pigmenti, or hypomelanosis of Ito, the skin lesions are going to follow the Blaschko's lines. And please remember that in all these conditions also the lesions do not cross midline. Do not cross midline. So what is the other type of lesions in dermatology which do not cross midline? So those are the lesions that follows the dermatomal distribution. Dermatomal distribution like herpes zoster, like our segmental vitiligo. So all these things are going to be dermatomal distribution. But this is Blaschko's lines, and Blaschko's lines is also not going to cross the midline. No, does not cross the midline. So let's move to the next question now. Which of the following is not used for the treatment of vitiligo? So the question is about vitiligo. They have tested you regarding the treatment part. What is the answer? Options are retinoids, systemic steroids, psoralen pua, and pimecrolimus. What is the right answer here? So in vitiligo, C may not be the right answer. No, something else. Okay, let us see why are you going for C. See, always remember that in vitiligo, what is happening in vitiligo? As you already know, it is a autoimmune disease, isn't it? Vitiligo is an autoimmune disease. So whenever there is an autoimmune disease, so our body is going to attack our own cells, isn't it? So we have to bring down this immunity. So obviously we'll be giving some immunosuppressive agents like steroids and many other immunosuppressive agents. So when it comes to the treatment part of vitiligo, our drug of choice for vitiligo is going to be a calcineurin inhibitor. It's called as tacrolimus or pimecrolimus. So these both are called as calcineurin inhibitors. These both are calcineurin inhibitors. Whereas in vitiligo, one of the majorly used treatment, we can also use steroids. We can use systemic steroids also, or we can use topical steroids also, can also be used because it's an autoimmune disease, isn't it? Now we can also use other immunosuppressive agents, immunosuppressives like azathioprine. All these things can be used because these are going to reduce the autoimmunity. And then along with that, a very important treatment modality is phototherapy. A very important therapy is phototherapy. So what we can use in phototherapy, we can either go for UVA or for UVB. So in UVA, what is used is PUVA, that is psoralen, that is combined with UVA, can be used, or narrow band UVB can also be used. So remember, phototherapy can also be done. And then along with this phototherapy, in some stable kind of vitiligo, we can also go for a skin grafting as well. So all these are various treatment modalities that is possible today in the management of vitiligo. Now let's go back to this option. So I think now all of you have got the answer. Jayasurian, MedPsycho, Satyajit, all of you are answering right. Retinoids is not used. Where is retinoids used? Retinoids is used in acne vulgaris, isn't it? But retinoids is not used in the management of vitiligo. Whereas systemic steroids, psoralen, pimecrolimus, all these things can be used in the management of vitiligo. So I hope that is clear. So now let's go to the next one. So sang smear as shown in this image shows. Now it's a black and white image that you can see. Now what can you see in this image is that you can see rounded cells, correct? So you can see some rounded cells with a large nucleus. So rounded cells with large nucleus, what do you call for these kind of cells under a sang smear? Any answer? So some of you are answering it as C, some of you are answering it as B. Okay, so now let's see what is the right answer. See, what is a sang smear? Sang smear. See, just concentrate here for a minute. Like in sang smear, what happens is that whenever you get any kind of a vesicular or vesiculobullous lesions, we can just de-roof the vesicle and examine under the microscope. Under microscope. Yes, king of medico, cyclosporin is a immunosuppressant. Very good. So excellent. So now what am I talking about? I'm talking about sang smear. So whenever you have some vesiculobullous disease like chickenpox, it can be herpes simplex, it can be herpes zoster, isn't it? It can be pemphigus vulgaris, like vesiculobullous diseases, pemphigus foliaceus. In all these diseases, we can do this test called as a sang smear. So in sang smear, when we examine under the microscope, there are two findings that is possible. The first finding in a sang smear, it can be a multinucleated giant cells. Now what is a multinucleated giant cells? So these multinucleated giant cells can be seen in infections like chickenpox or herpes simplex virus. Fine. And whereas the second finding in a sang smear is called as a sang cell or a acantholytic cells. Acantholytic cells. And these are seen in pemphigus group of diseases. In pemphigus group of diseases. Now what is happening in a sang cell or a acantholytic cell? Usually the keratinocytes, they are attached to each other. And what attaches a keratinocyte, one keratinocyte to the other? These are attached to each other because of a desmosome. So these are keratinocytes which are usually attached to each other. And once there is a defect of this desmosome, what happens? This keratinocytes get detached from the other keratinocyte. So once they get detached, these becomes rounded cells with a large nucleus. And these are called as acantholytic cells. So in this MCQ, what has been given, you can see that there are multiple rounded cells with a large nucleus, and these are going to be called as acantholytic cells. And in case in the next exam they may ask you, like, in which disease can we see this acantholytic cells, the answer is going to be pemphigus group of diseases like pemphigus vulgaris, pemphigus foliaceus, pemphigus vegetans, etc. Fine. So now let's move to the next one. Identify the condition given below. Chickenpox, eczema, molluscum contagiosum, impetigo. See, earlier we have seen something around the lips area. So this image is also something similar. So I have told you what are the differential diagnoses when you see some crusted lesions. It can be either herpes simplex virus or it can be impetigo, isn't it? So here the right answer would be impetigo. Fine. So in impetigo, what is this type of impetigo? I'll just zoom this image for you. So which type of impetigo is this? Is it a bullous impetigo or a non-bullous kind of an impetigo? So Jayasurian, S, Yogi Mahendra, Khan, all of you are answering it right. So this is going to be a non-bullous impetigo, which is also called as impetigo contagiosum. Impetigo contagiosum. And can you just revise it once again? What is the most common organism that causes impetigo contagiosum? This is usually caused by, is it streptococcus or is it staphylococcus? Non-bullous impetigo. This is usually caused by streptococcus more than staph aureus. Okay, this is caused by streptococcus more than staph aureus. Fine. So now let's move to the next one. Identify the lesion that you can see over the trunk. Now what is the lesion that you can see over the trunk here? See, in this previous question, please don't make mistakes. Okay, whenever you see the small kind of lesions, okay, these are going to be non-bullous kind of an impetigo, and that is usually caused by strepto, not staph aureus. Fine. Okay. Now please concentrate on this question now. What is the type of lesion that you can see over the trunk? Options are pityriasis alba, pityriasis rosea, just pityriasis is given. So let us say pityriasis versicolor and chickenpox. So few of you are answering it as A, like pityriasis alba. Some of you are answering it as B, pityriasis rosea. Okay, so here the right answer is going to be B, that is pityriasis rosea, and I'll explain you why. Because first thing, in pityriasis rosea, so once you see this image, what is that lesion that catches your attention? The first lesion that catches your attention is this biggest lesion, right? You can see multiple lesions here, but out of all these things, the one that catches your eyes is going to be the biggest lesion. And this big lesion is actually the first lesion that develops in pityriasis rosea, and this lesion is called as the herald patch or mother patch, and this lesion is called as the herald patch or the mother patch. That is the first lesion that develops, and after few days what happens, multiple smaller lesions start developing over the trunk. Multiple smaller lesions start developing. Small lesions start developing later, and these small lesions, they are going to have a very peculiar kind of an arrangement over the trunk, and this can be compared to a Christmas tree pattern. So this is compared to a Christmas tree pattern. So this is going to be compared to a Christmas tree pattern or a fir tree pattern. Fine. So all these are the various findings that you see in pityriasis rosea, and remember that this is a self-limiting condition. This is a self-limiting condition. So which means that there is no specific treatment that is necessary. So these lesions are going to subside in several weeks. So probably it may take several weeks. Now if you examine these lesions, people are already answering in the chat box. So if you examine these lesions, there is a peculiarity for the scaling that you see in these lesions. So what is the peculiarity of the scaling? The peculiarity of the scaling is that the scaling is in the periphery. Scaling over the periphery of the lesions, and these peripheral scales are compared to a collarette of scales. Collarette of scales or cigarette paper like scaling. Cigarette paper like scaling. Fine. So these are going to be collarette of scales or cigarette paper like scaling. So all these are the important topics regarding pityriasis rosea. Now let us try to understand why some of you made a mistake with the answer pityriasis alba. So in the chat box, of course beyond the horizon you will be able to do all these topics. Fine. Also wishing you all the best. And Med Psycho is saying yes. So in pityriasis alba, just concentrate here for a minute. In pityriasis alba, what is the commonest clinical presentation? The patient is usually a child. So this is usually a child who complains of multiple hypopigmented patches over the face. So these are those child around 8 to 10 years of age with complaints of multiple hypopigmented patches over the face. That is called as pityriasis alba. It is considered to be a type of a dermatitis, but one of the very important differential diagnosis when it comes to pityriasis alba is going to be indeterminate leprosy. Because in India, whenever you see these hypopigmented patches, we always think about leprosy, correct? So one of the very important differential diagnosis when it comes to pityriasis alba is indeterminate leprosy. But in pityriasis alba, do you expect any kind of a sensory deficit? Absolutely no, isn't it? So the sensations will be all intact. That is going to be seen in pityriasis alba. Fine, that is all about this question. So now let's move to the next one. So what is the next question? That Fordyce spots involves in which of the following? So sweat glands, mucus glands, sebaceous glands, small glands. So what is Fordyce spots? So Fordyce spots, I don't have an image today of Fordyce spots, but these Fordyce spots are actually ectopic sebaceous glands, correct? So these are ectopic sebaceous glands. So since these are ectopic sebaceous glands, they usually do not require any treatment. So okay, multiple answers in the chat box. Okay, so these are ectopic sebaceous glands. So these are ectopic sebaceous glands and do not require any treatment. So what are these spots? It is usually seen over the lips. or over the shaft of penis. Fine. So you can see some whitish spots over these lips, and this is called as a Fordyce spots. Now what is important for your MCQ is that in the MCQ they may give you two options, like there is another condition called Fox-Fordyce disease. Now what is Fox-Fordyce disease? Fordyce spot is going to be a ectopic sebaceous gland, whereas Fox-Fordyce disease is a disease condition of, yes, it is a disease condition of apocrine sweat glands. So in physiology you must have learned, where do you find these apocrine sweat glands? So where do you find these apocrine sweat glands? Apocrine sweat glands are seen in the axilla. They can be seen over the areola, they can be seen over the groin area, isn't it? So apocrine sweat glands. So this in this case the patient usually presents to you with itchy papules over the axilla, and this is a disease condition which may require treatment, whereas Fordyce spots are going to be ectopic sebaceous glands, and those usually do not require any treatment. So please make sure that you have a clear picture about Fordyce spots and Fox-Fordyce disease. So moving to the next one, the condition where Nikolsky sign is positive and Wallah spread sign is seen. Options are dermatitis herpetiformis, pemphigus vulgaris, bullous pemphigoid, and erythema multiforme. So where do you find Nikolsky sign and Wallah spread sign? For that, first we should know what is Nikolsky sign, correct? So what is Nikolsky sign? So many of you are answering it as B, that is pemphigus vulgaris, and that is the right answer. So I'll just let you know, like, why is it pemphigus vulgaris? So S, Jayasurian, Ashrafi, Rahman, all of you are answering it right. Okay, so now listen what is Nikolsky sign. So whenever we apply a tangential pressure over the skin, if the skin would peel off, this is called as Nikolsky sign. Okay, so apply tangential pressure, and the skin peels off, this is called as Nikolsky sign. Now in which diseases do you find this Nikolsky sign positive? So Nikolsky sign positive can be seen in pemphigus vulgaris, pemphigus foliaceus, and this can also be seen when there is a defect of desmoglein 1. We discussed about this condition today. Do you remember that which is that condition where there is a defect of desmoglein 1? It can be caused due to staphylococcal toxins in the blood. What is that condition called as? This is called as staphylococcal scalded skin syndrome. So in all these conditions we can see Nikolsky sign positive. Fine. So in all these conditions, what is the etiology? The etiology is going to be because of a defect of the desmogleins or the desmosome defect. Fine. Now they have also mentioned about another sign which is called as a Wallah spread sign. Okay, Wallah spread sign, or there is a similar other sign which is called as a Asbow-Hansen sign. So these are the two different signs that you can see in these bullous diseases, where we are trying to manipulate this bulla. So suppose there is a bulla here. If I am going to press it from the sideways, okay, the bulla is going to spread. This is called as a Wallah spread sign. Or we can give a pressure on top of the bulla, and if this bulla is going to move, this is also considered to be some of the signs that is elicited in vesiculobullous diseases. Fine. Yes, so this too can be seen in pemphigus group of disease. Now, yes, now today we have discussed about another drug reaction which is called as Stevens-Johnson syndrome and toxic epidermal necrolysis. So in Stevens-Johnson syndrome or toxic epidermal necrolysis, what we can see is a pseudo Nikolsky sign. pseudo-Nikolsky sign. Why is it called as a pseudo-Nikolsky sign? Because here the etiology is going to be different. So why is the etiology different? Because earlier in all the pemphigus group of diseases, what was the etiology? There was a defect of the desmogleins, isn't it? Whereas when it comes to Stevens-Johnson syndrome and toxic epidermal necrolysis, there is a different etiology. That is because of this drug reaction. So hence the same clinical test, that is apply a tangential pressure, the skin peels off, the same test is called as a pseudo-Nikolsky sign because of the difference in etiology. Fine, that is about Nikolsky sign. So now let's see the next question, and this next question is regarding the causative. The shown image is the causative agent of. So what is seen in this image? This is a KOH image after doing a skin scraping of a patient who probably had a very itchy skin disorder, and it's a very contagious disease as well. What is the right answer? So this is called as scabies. What is the name of this organism? So the name of this organism is Sarcoptes scabi. So the name of the organism is Sarcoptes scabi. Medpsycho, Rajrana, Yogi, Mahendra, Jayasuriyan, Ashrafi, Rahman, all of you are answering it right. So this is Sarcoptes scabi. So this is the KOH image of a Sarcoptes scabi, which is a causative organism of scabies. Now in scabies, what happens? What is a typical skin lesion? The typical skin lesion that you can see in scabies, what is it called as? The typical skin lesion in scabies is called, yes, it's called as the burrows. So what are burrows? These are S-shaped serpiginous pathway that you can see especially around the finger webs. Okay, you can see around the finger webs. And what is the drug of choice when it comes to scabies? So the drug of choice when it comes to scabies is, yes, so this is going to be 5% permethrin. So 5% permethrin can be used in the management of scabies. So yes, so with that we go to the next question. So identify the type of nevus that is shown in this image. So Shiva Shankari, Medpsycho, all of you are answering good. So now let's see what is this type of this nevus. Now what do you see in this image first? Let us not look into the options. So in this image, what do you find? So you can see that there is a hyperpigmented brownish patch lesion over the trunk of a patient along with an increased hair growth, isn't it? Which means hypertrichosis is also present. So in which kind of nevus do you get this brownish hyperpigmentation along with hypertrichosis? Yes, this is seen in Becker's nevus. So all of you are answering it as right. That is Becker's nevus. You get a brownish hyperpigmented patch with hypertrichosis. So this is a spotter image for a Becker's nevus. Now what do you see in the case of a nevus of Ota? So any idea what is nevus of Ota? What is the color of the skin lesion in nevus of Ota? So when it comes to nevus of Ota, this is one of the skin condition where you get a bluish discoloration of the skin. So whenever there is a bluish discoloration, one of the findings is nevus of Ota. There is another finding called nevus of Ito, and there is one more finding called Mongolian spots. All these things are going to be examples of dermal melanocytosis. Now where do you find this nevus of Ota? This is seen as a bluish discoloration around the eyes. Okay, that is seen over the face or around the eyes area. So that is called as nevus of Ota. Whereas if there is a bluish discoloration of the shoulder area, you call it as nevus of Ito. I-T-O. Fine. And in which disease do you find this plexiform neurofibroma? So in which disease do you find a plexiform neurofibroma? Yes, plexiform neurofibroma is seen in neurofibromatosis. It is seen in neurofibromatosis. And cafe o lait macules, these can also be seen in neurofibromatosis, isn't it? Very good. So here the right answer is going to be Becker's nevus. So yes, I think with that we are coming towards the end of our discussion of dermatology PYQs in FMG exam. I hope that the entire session was useful for all of you, and thank you very much for this very responsive session. All of you were very much responsive in the chat box, and the exam dates is not yet announced, and I hope that all of your preparations is going fine. So tomorrow I think we have sessions of psychiatry and psychiatry coming up in the next 2 days. So please continue following all the social media channels of PW MedED. And thank you so much for your patience and your listening to these lectures. So I'll again see you soon with the next session that is coming up with PW MedED. So no Rajrana, there is no update release for FMG yet. Okay, thank you so much, MedPsycho, Rajrana, Shiv Shankari, all of you. So I'll see you soon again. Thank you so much.